we were starting to discuss adenocarcinomas. And the first thing that's going to bring your attention should be Barrett's. Heterotrophic gastric or submucosal glands. Barrett's esophagus, esophagitis, marked by metaplasia of the distal esophageal squamous epithelium, trochlear epithelium, in response to what should be a prolonged injury. It's most common in us adults, but may be seen in children and infants, and it'll base to a long-standing gastroesophageal reflux, which is going to lead to inflammation and ulceration of the squamous mucosa, and the healing is meant by epithelialization by pluripotent stem cells and the presence of a low pH environment. The morphology, you're going to have red velvet mucosa existing as an irregular sort of circumferential band at the gastroesophageal junction. It may also take the form of linear streaks or isolated patches of metaplastic mucosa in the distal esophagus. Now, when you see it in a microscope, microscopically, you'll see a mixture of gastric and intestinal type columnar epithelial cells. These epithelial cells are mucin secreting and absorptive, and there's a substantial risk of ulceration. And of course, adenocarcinoma, which Barrett's makes it 30 times higher than the normal risk of cancer. So that's what we have to think about Barrett's when we think about adenocarcinoma. Oh, thank you for reminding me. You don't see the clock. Can you see it now? I was just talking like a parrot here, and I forgot I had to. Okay, thanks. Sorry for that. Thanks, Brian. I just started shooting out and forgot that I had to click the little view icon. Sorry for that. Here, the transition of a normal squamous esophageal mucosa into a glandular or intestinal type of a mucosa. What I mentioned about Barrett's, you see the squamous epithelium. This will be when it's esophagitis. This is the Barrett's esophagus with the dysplasia and the carcinoma. Notice the carcinoma invading the submucosa and making it all the way to the basement membrane. The lecture should be in the Google Drive. It says CH17, and it's in the form of a PDF file. Of course, in the PDF, you're not going to get these comments, which are meant for the lecture. And also, it's available in my library website. If you're new to the class, send me an email, and I will give you more instructions as to the particulars on how to get access to what. And I'm typing my email in the chat box. The chat box is the little rectangular icon that you have in your GoToWebinar thing. If it has a plus sign, click it, and it's going to expand, and you'll see everything that I write in there. There it is. Dr.Martinez@USATMedicalSON.org. If you're new to the class, in other words, you started brand spanking new today, send me an email so I can get you hooked up with all the peculiarities, nicks and knacks of the course, okay? This is Barrett's esophagus. This is adenocarcinoma. Notice here on the right side, when I mention the morphology, I mentioned the morphologic properties of it. You have a mix of gastric and intestinal type of columnar epithelial cells, barely noticeable here because the architecture has pretty much been compromised at this point. Now you see the mucin secreting cells here. Wait a second. Let me use my let's write in red and use the pen. These are the mucin secreting cells here. These are all mucin secreting cells. They're absorptive also. And all this carries a substantial increase to ulceration, as you see in the gross picture on the left. Now let's go to the stomach. You should know the normal anatomy, histology, and physiology of the stomach from your anatomy, histology, and physiology class, so we're not going to go over that. We're going to be dealing with the pathology. From the pathology-wise, you should think about congenital diseases, gastritis, peptic ulcer, hypertrophic gastritis, varices, tumors, benign adenocarcinomas, and others. And as my comment there, as you see, it's just a comment to keep you awake. We're now moving down on the GI tract. Our next stop is the stomach. We're stopping at the stomach. Remember, we started in the mouth, worked our way through the esophagus. Now we're in the stomach. Yeah, and you can imagine where the course is going to end by the end of slide number 187. There should be the rectum. We're going by parts. Segments. Imagine, as I used to tell my students, imagine you are, let me put it in a nice way, that you are a food particle. You become food bolus. And you start in the mouth, and you're making your way through the entire body, and way out. That's how pretty much we're going to put it. So you can visit every stop that the GI system encompasses. Okay? Anatomy, you have the cardia, esophagus, fundus, body, which is very acidic, antrum, pylorus, the greater and lesser curvatures. This is just a broad review. Can hold 1,500 to 300 milliliters of contents. You have the stomach has rogae, innervations via the vagus and sympathetic nervous system, with the portal vein being the most important venous portion on it. Blood supplies, you have right gastric, left gastric, right gastric esophageal, left gastric esophageal, etc. All three branches of celiac artery, no matter what the variations may be, etc., etc. You should go over your review on your anatomy lecture. If you have a book, fine. If not, you can find this also in the electronic library. Well, it says anatomy and physiology presentations with great details. Those lectures have great details. But I don't want to step on the toes of whoever's teaching anatomy or physiology. So just as a reference, it's like when you go to the library and you have many books as reference and you pick and choose whatever you want to read, right? This is the arterial supply of the stomach, you see all three classic branches of the celiac axis supply to the stomach, with the common hepatic, left gastric, and splenic arteries involved. Why you should know these? Because sometimes if one of these blood vessels gets obstructed or compromised, you may have some pathologies associated with it, correct? If you think the acid production in the stomach to be the only in the mid-body and the proximal and distant ends of the chiefly mucus to protect the esophagus and duodenum from the harsh acids, then you will understand the histology as well. This is, again, broad review for anatomy, in this case histology. Let's cut this little piece of stomach here, the border of the stomach. Greater curvature, right? Lesser curvature. Rogae. This is the mucosa, with the mucosa muscularis serosa, and you see the gastric pits with simple colon epithelium. That's awful. This one is better. Single colon epithelium, the lamina propria. This is the gastric gland. This is a lymphatic nodule. This is your muscularis mucosa, lymphatic vessels, venules, arterioles, part of the oblique layer of muscles. This is circular layer muscle. This is the infamous or famous plexus of Auerbach and longitudinal layer muscles with the mucosa, submucosa, muscularis, and serosa. Pretty cool, huh? I'm borrowing this from the anatomy slides. This is the gastroesophageal juncture, which is a squamocolumnar juncture. Is there a sphincter around here? No. No, there's no sphincters around. You'll see them. They'll have this cute tubule-like architecture. Both the proximal and the distal ends of the stomach neutralize acids with alkaline mucus rather than producing acids. Very important, ladies and gentlemen. That comment there is very important because it's prone to confusion. And I'm putting up that comment in the chat box. Pardon me, I'm drinking a little bit of water, 103 degrees out here today, so it's a little bit miserable. My apologies. This is the body of the stomach with numerous chief and peritoneal acid-producing cells. Peritoneal cells which produce acids. Okay? This is a pyloric sphincter. And note a few submucosal glands on it, seen a little before the sphincter itself. Going back to our presentation, cells, you're going to have mucous cells, chief cells, parotial cells, enteroendocrine cells, which produce histamine, somatostatin, endothelium, each cell with what they produce. And somatostatin, which is also known as growth hormone inhibiting hormone, GHIH, or somatotropin inhibiting factor, is a polypeptide, regulates the endocrine system and affects neurotransmission and cell proliferation through the interaction with G proteins coupled with somatostatin receptors and inhibition of release of numerous secondary hormones, and the endotheliums, which are proteins that constrict blood vessels and raise blood pressure, and pepsinogens, which are precursors of protein hydrolyzing pepsin. All right? Physiologic phases of hydrochloric acid secretion. You have the cephalic phase, the gastric phase, and the intestinal phase. And the cephalic phase is initiated by a very sight, taste, smell, chewing, swallowing of palatable food, mediated by the vagal activity. In other words, when you're outside, this weekend is prone to that. You wake up or you go out in your backyard, and you, Monday morning or Monday at around noon, you get this great smell of barbecue, and your mouth waters. That's part of the cephalic phase. You smell it, and you say, wow, someone's doing some good barbecue around the corner, right? And then the gastric phase, which involves the stimulation of stretching receptors by gastric distension and is mediated by vagal impulses. And it's also involved in releasing gastrins from the endocrine cells, the G cells, the antral glands, gastrin release promoted by amino acids, peptides, and most likely vagal stimulation too, right? And the intestinal phase, last but not least, when food containing proteins that are being already digested will enter the small intestine, and that will have a series of polypeptides besides gastrin involved. Acid protection, mucus, bicarbonate, how the stomach protects itself from all the massive production of acid by mucus, bicarbonate, epithelial barriers, blood flow, and prostaglandin E in one. So, a good analogy, prostaglandin E both decreases acids and increases mucus. And why it's increasing mucus? Precisely to protect from the acids. That's the logical explanation and the logical analogy for it. So prostaglandin E is going to decrease acid and at the same time increase mucus in order to protect the system, the stomach, from the acids, excessive acids. Sometimes, as we know, there's not enough production of prostaglandin E's because that should explain why some people end up with ulcers, correct? Congenital diseases. The stomach develops like a lungs from the foregut, and that's if you want to understand developmental anomalies, which you should, because they're not only important for our class here or for your USMLE studies, but basically for your practice if you're going to specialize in gastroenterology, or if you're heading to a rotation in gastroenterology soon. Ectopic pancreas, affecting the ectopic pancreas tissue, stomach, which is very common. Ectopic gastric, affecting ectopic gastric tissue, not rare at all. Affecting the pancreas. Diaphragmatic hernias, probably more common than we might think, right? Which is a failure of the diaphragm to close. And pulmonary sequestration, that one is rare, which is a foregut anomaly and the #1 congenital gastric disease. Being the #1 congenital gastric disease being pyloric stenosis. Which is on my next slide. Pyloric stenosis, which is congenital, affecting 1 in 500 births, neonatal obstruction symptoms, pyloric splitting, which is curative. That's the acquired, that's the congenital version. The acquired is secondary to extensive scarring, like the one in advanced peptic ulcer disease. And what will be the #1 symptom on a baby? You got it, vomiting. What kind of vomiting is that? It's the famous, and if anyone here is familiar with rockets, the word starts with P and ends with E. Projectile. Correct, Janelle. Thank you. Non-bilious projectile vomiting. I always make the analogy with rockets. Projectiles. Of course, a projectile can also be a bullet or a pellet. or BB, or anything that you forcefully launch. It could be a stone, a little rock from a slingshot. That's also a projectile. Anything that's flying with trajectory and direction, right? Has magnitude, direction, etc. That will be from the class with Dr. Einstein, I think. I'm stealing his material. Shh, don't tell him anything. I'm kidding. Gastritis could be acute, chronic, autoimmune, eosinophilic, allergic, lymphocytic granulae, due to GVH. The acute chronic patterns of gastritis conforms to principles that we also have referred to, and the other category of this is histologically based. We hear the term a lot, right? Such and such person has gastritis. Now, let me ask you a quick question. What is gastritis? In the simplest terms, how do you define as gastritis? If you're going to divide the words, right, by root, gastritis. What is gastritis? On your own words. Look at me. I'm thinking about parasitic infections already. In your own words. Don't confuse, ladies and gentlemen, future doctors, the words infection and inflammation. Two huge different concepts. An infection can produce an inflammation, but an inflammation is not necessarily out of an infection. For example, you can get a punch on the lips, like a boxer, like boxers. Let's say you're Juan Manuel Lopez, and you're fighting another guy named Salido, for example, and he beats the living bejesus out of you and punches you hard on the lip, and you get a swollen lip. That was out of an inflammation. It was not out of an infection. That's an inflammation of the stomach and its linings. Okay? Inflammation. Remember the word itis? I mean the root here, itis. It's an inflammation. All you have to do is find what the first root is, and voila. You pretty much solve your problem. There's acute and hemorrhagic gastritis, and normally the reasons: non-steroid anti-inflammatory drugs, especially aspirin. That's probably the most commonly presenting one in the ER. Excessive alcohol consumption, heavy smoking, chemotherapy, uremia, salmonella, cytomegaloviruses. Now you see there is an inflammation. There is an inflammation produced by an infection when you have characters involved. Which characters? In this case, salmonella, cytomegalovirus, or H. pylori, right? Or it could be triggered by severe stress, trauma, burns, surgery, anxiety, ischemia and shock, suicidal attempts with acids and alkalis, gastric irradiation or freezing, very rare, by the way, unless you drink liquid nitrogen, mechanical due to an nasogastric intubation, and mechanical also due to distal gastrectomy. In other words, we cause that. Physicians, surgeons will cause that one, right? The concept and histological changes in the acute and the chronic patterns will follow the classic histologic principles: acute polys, chronic monos. However, the main clinical differentiation between acute and chronic gastritis will be based by the presence of blood, respectively. That is a very, very important concept that you all should memorize, effective immediately. Now it's in your chat box. Remember, gastritis, inflammation of the gastric lining mucosa. You have acute and chronic. Acute, usually transient, and chronic, that will be leads. The chronic one also, will know that's not there. The chronic one leads to mucosal atrophy and epithelial metaplasia, which constitutes a background for carcinoma. Okay? The concepts and histological changes. Acute to the left and chronic to the right. Follow the gastric histological principles. Acute, chronic. Acute. Better. This is hemorrhagic. See the blood, presence of blood. Chronic with non-erosions, no hemorrhages, and the main infectious agent will be H. pylori. It's autoimmune, toxic with alcohol and cigarette smoking, post-surgical with reflux of bile, motor and mechanical, including obstructions, Bezors, gastric atony, radiation therapy, granulomatous condition, or radiation exposure, uremia, GVH. And think about Crohn's disease also. On my comments, acute gastritis, you have hemorrhage, erosions, neutrophils, chronic, monos, no hemorrhage, no erosions, and don't forget the chronic of the chronic always follows. Remember, chronic gastritis, no erosions, no hemorrhages, some neutrophils, lymphocytic lymphoid follicles, with regenerative changes leading to metaplasia, intestinal metaplasia, atrophy, mucosal hyperplasia, thinning of the lining, and dysplasia. If you don't hear me, I'm just pausing so you can catch up writing. You are free to record these lectures. Something that I think I forgot to mention recently, in other words, within the last couple of sessions. You are free to record the sessions. I am not one of those gung-ho hardcore characters who takes to offense being recorded during a lecture. As long as it's for personal use, you're not using it for commercial gain and posting them all over the internet. That will be extremely unethical. For personal use, absolutely. Excellent. Yeah, I forgot to mention that. Yeah, you're free to record the sessions. And then once you record them, you can go back to the PowerPoint presentation, and it's going to make a little bit more of sense to you that way, okay? You're very welcome. I used to record them, but unfortunately, the space it takes in order to upload them, it's terrible. And I was told that we couldn't do it because of that logistics issue, some logistic issues with that. Eventually we'll get there. But in the meantime, go ahead and use your favorite recording device. Now we go to our friend and what I characterize as our sociopathic bacteria, Helicobacter pylori, right? Gastric biopsy here with silver stain on the left, and Giemsa stain here on the right. These adhere closely, these bugs, Helicobacter pylori, they will adhere closely to the gastrocmucous mucin rather than to invade the epithelial cells. Kind of a very selective bacteria if you consider it, the mechanism of action and the way it decides to destroy the stomach mucosa, right? Now, to entertain my dear students, you can open your Google browser. Tell me, how do you treat Helicobacter pylori when you confirm it? At first, how do you confirm you have a patient who's suffering an invasion of Helicobacter pylori, and how you would treat it? Let's say you're in a small town called Maricao, in a remote part of the island of Puerto Rico, and there's no gastroenterologist there, or you're in San Sebastián del Pepino or somewhere there, or somewhere in Valle del Cauca in Colombia, and you're the only doctor around. And you suspect that your patient has Helicobacter pylori. How do you diagnose it, and how do you treat it? I'll give you 5 minutes to come up with the answer and bombard me in your comment section. I'll be waiting. I can tell you it's a gram-negative rod. Let me start facilitating that to you. It's a gram-negative rod. Oh, I'm prohibited from doing that, Hugh. I'm sorry. It was one of my first ideas, and they said, no. Cool. So, sorry for that. Okay, antibiotic therapy. We have a good start here. What kind of antibiotic therapy would you use to treat Helicobacter pylori? H2 blockers, PrevPack twice a day for 14 days, amoxicillin. What is the POC? I see the magic words by Neil. Triple therapy. If available, Wanda, good point. If available, get blood tests, treatment with the triple therapy. If available. Very good point, because I told you I assume I am in a remote part of Puerto Rico or in the island of Cuba or Dominican Republic or somewhere in Colombia where I don't have a lot of resources. Triple therapy, PPI, amoxicillin, clarithromycin, which, you know, some people give the commercial names or give the generic name. I'm fair for that. Biaxin, omeprazole, amoxicillin, clarithromycin, Pepto, which is Bismuth, right? Don't be afraid of participating. There's no points taken or no points added for your participation. Even if your answer is not theoretically the correct answer, we're here to learn. We're not here to penalize or criticize anybody. I'm not an SSBN, a submarine with ballistic capabilities to wipe you out and sink your ship. That's not my purpose here, okay? Now, there's a risk with raising the stomach acid. The risk is if there's already an erosion in the lining of the stomach, then that's going to contribute to, or facilitate, I should say, it's going to facilitate to a possible aggravation of a potential acid-lowering drugs. Acid-lowering drugs, okay. The autoimmune but gastritis accounts for 10% of the cases with antibodies against acid-producing enzymes, potassium ATPase, gastrin receptors, and intrinsic factors. Now, the question that I have there, which has the answer already, would an autoimmune gastritis be associated with megaloblastic anemia? Sure. Why? Because there's going to be a decrease in intrinsic. Start from there, and then you make up the rest. Your first answer should be, if these were rounds, which is what we do on Tuesdays, not today, but if this was the Tuesday class, I would have asked you, why? And if you would have popped, because there's a decrease in intrinsic factor, yeah, okay, and move on. You're out of the woods. Then, for brownie points, then you add the rest of the stuff. No doubt, achlorhydria will be the common factor of chronic gastritis and B12 megaloblastic anemias. But your first thing that should pop up in the back of your brain from your backup files will be decrease intrinsic factor. That's what we do on Tuesdays. We brainstorm on Tuesdays. On Thursdays, we come to learn and listen and be attentive. The difference is Tuesdays is an elective class. Thursdays is, I think it's a required class. Other types of gastritis: eosinophilic, allergic, lymphocytic, granulomatous, GBH, and eosinophilics. Middle-aged women are the preferred, the most affected. Allergic will be children, also eosinophils. Lymphocytics with T cells, T cell bodies, diffuse. Granulomatous, think about Crohn's and other granulomas. And GBH and bone marrow transplants, very rare though, but they do happen. How often these are asked in tests? Not that much. These other, not that common. Examiners tend to focus on Helicobacter pylori and congenital and acquired than the others. So this is not what I would call high-yield material. And remember, a chronic gastritis chronic, you have a chronic mucosal inflammatory change, which is going to lead to mucosal atrophy, epithelial metaplasia, and in the immunologic version of it, you have antibodies to peritoneal cells. It's pretty much what I can bring from the back of my brain. Of course, we're going to go over gastric ulcerations and acute gastric ulcerations pretty soon. This is eosinophilic gastritis, presence of eosinophils, sure, but these were granulomas rather than eosinophils. What kind of gastritis will be? Would it be the eosinophilic gastritis? It's a rhetoric question, just to mess up with you. Lots of eosinophils. Let me use a spotlight. And let's go to our favorite subject, peptic ulcers. You're going to see these, if you are, pardon me, I'm sort of old school here. No intention to offend anybody. But I'm from the days where there used to be something called general practitioners. Peptic ulcers, general practitioner stuff, yeah, they used to treat it all the time. Peptic implies acid cause aggravation, ulcer versus erosion. Think about the muscularis mucosa being intact, affecting the mucus, mucosa muscularis and serosa, with chronic solitary, usually in adults, 80% caused by, 80% of them caused by Helicobacter pylori, okay? And when it's in the duodenum, 100% caused by Helicobacter pylori. Of course, non-steroid inflammatory drugs and stress. Notice the difference here. When it's duodenal, it will be 100% of the time caused by our pal H. pylori. Then you have non-steroidal anti-inflammatory drugs, abuse of them. In other words, you like to pop up indomethacin like crazy. Remember on Tuesday we had a case like that? For those of you who are taking the Tuesday Introduction to Clinical Medicine, we had the case of the non-steroid anti-inflammatory drug abuser. Yeah, we have those too, even though it don't produce a high or anything, but it does produce peptic ulcers. For those of you that were in the ICM course, remember what our case last Tuesday, which, by the way, the cases are posted, even if you're not taking the ICM class, the cases are posted in the Google Drive. They have a case name, a very strange case name, and the date on it, okay? So even if you're not taking the class, at least you can take a look at them and Helicobacter pylori causes 80% of gastric peptic ulcers, 100% of duodenal peptic ulcers, chronic gastritis, gastric carcinomas, and mouth lymphomas. What are mouth lymphomas? Time for you guys to do your little research. Go to Google. Tell me what is a mouth lymphoma. Now is the time for class participation, even though I don't give any kind of points for it, but I really enjoy it. What is a mouth lymphoma? If you don't hear me, it's because I'm in mute, giving you some time to gather the answer. And that's the beauty of this class. It's like being in class, and I ask you, what is a mouth lymphoma? And you start flipping pages in your textbook. Same thing, you can do whatever you're doing right now, flipping pages in your textbook, or going online on Google or Yahoo or whatever your search engine is and finding it out, okay? Mucosal associated lymphoid tissue. Amen. Which is a malignancy of the flora of the mucosa, right? Solid tumors originate from cancerous growth of immune cells recruited to secretory tissues like the gastrointestinal tract, salivary gland, lungs, thyroid glands, okay? A form of lymphoma involving mucosa-associated lymph tissue, frequently of the stomach. Cancer originate B cells and marginate zone, okay. Lymphoma involving the mucosa-associated lymphoid tissue, okay. And as a rare B-cell non-Hodgkin's lymphoma that typically runs an indolent or slow-growing clinical course, and it's an acronym for mucosa-associated lymphatic tissue. That is correct. Affecting the extranodal margin, extranodal margin zone B cell. Perfect. Atta guys and girls. That's what I wanted. Ulcers if you're going to ask me grossly how they look, sharply punched out. You have to look at these punch outs on the mucosal borders. And they can affect the 4 layers, all 4 layers. Mucosa, submucosa, muscularis, adventitia, everything. What is the pathogenesis of ulcers? Good question. Yeah. Well, think about an imbalance between gastroduodenal mucosal defense mechanisms and some damaging forces. And the damaging forces throw in there gastric and acid pepsins, of course, H. pylori infection, abuse of aspirin or NSAIDs, cigarette smoking, too much alcohol, impaired acid secretion regulation, stress, you know, your boss has it on you all the time and you hate the boss but you don't want to tell him and you suck it up. Or you're an air traffic controller and you're under stress all the time, and rather than recurring to use recreational drugs, you pretty much suck it up. I got a solution for that. Buy a violin, buy a musical instrument, and vent out through one of the beautiful performing beautiful arts, right? Or if you are one of these type A personality guys, just go to your local academy, sports, and outdoor center, buy a heavy bag with a stand and a pair of boxing gloves, and just hit the heavy bag as much as you can for 3 minutes, and as hard as you can for 3 minutes. Trust me, your stress levels will go down dramatically. I am not kidding. This is serious advice. Serious, cheap advice. Or go out running, go out any vigorous activity. It's going to reduce those stress levels, right? By no means, and I'm not saying this criticizing anybody. By no means, please do not, if you are into shooting, do not buy a gun and do not practice shooting thinking the target is your boss. Normally that leads to very bad consequences eventually, okay? If you're going to be in the shooting thing, then get your hunting license and go out and, I mean, no offense either to all of you who hate hunting on that, but if hunting is your thing, go hunting. But by no means don't. Unfortunately, the statistical studies showing that people who go out practicing shooting thinking it's their boss, it's not a good thing, okay? Fishing could do the trick. Flying a kite could do the trick. Also, have you noticed, ladies and gentlemen, and now that we're talking about peptic ulcers and stressors, some people vent out stress by doing what? I already mentioned recreational drugs and some things, but there are 2 things that are very related to the subject we're studying, that if you do it because you're stressed out, you just aggravated an already bad situation. Which 2 things, and I mentioned them already in class, that some people do out there, start doing to relieve stress, and it has detrimental consequences for their health. And both are highly regulated by the government, by the way. You can drinking and smoking. Thank you, Gino. Some people start drinking. Guess what? You're aggravating that ulcer. Or some people just, hey, let me go and buy a pack of Lucky Strikes and smoke them. Others bent out on eating. Yeah, I forgot eating. But the ones that were literally speaking aggravate the situation will be drinking and smoking. And I mentioned them in class earlier. So if you're stressed out and you start drinking to relieve your stress, you're just throwing gasoline on an already burning fire. And if you start smoking, you're putting on layaway the inevitable. You're putting cancer on layaway. Let's go to peptic ulcers. Gnawing, burning, aching pain, epigastric. Those are we will all here in this classroom, we will all deal with a patient with peptic ulcers. It is as safe as saying that we were born to pay taxes and die inevitably. Well, when you choose to be in medicine, we all will see a case of peptic ulcers. Iron deficiency anemia, acute hemorrhage with penetration, perforation, pain radiating to the back of the chest and the lower upper quadrant. It's not felt to develop into malignancy, not felt. So if you're a doctor, throw into the good old saying, things that are inedible, taxes and death, well, throw in diagnosing a peptic ulcer. Question here. No, not with marijuana smoking. And anyone that says so, it's probably there's a hidden agenda. And I'm not a pro-marijuana guy. I really don't get involved in those things. But those studies might be skewed. Now, let me ask a question, poll question. Who has not? I know that most of you folks are nurse practitioners, nurses, PAs. Somehow you have been in the medical profession for some time now. Who has not yet seen a patient or referred to a patient who has had a peptic ulcer? Who has not? Who has not? Never seen a patient with peptic ulcer or with the symptoms? Because if you have not, I almost guarantee you that within the next 12 months you will see one. I'm not kidding. You will see one. The statistics are there to back this fact up. You will see one. And peptic ulcers, you have bleeding, which occurs in 15 to 20% of the patients, which is also the most frequent complication. It may be that bleeding may be life-threatening, not the ulcer. Accounts for 25% of ulcer deaths and may be the first indicator of an ulcer. Those with perforation, which occurs in about 5% of the patients, that won't account for 2/3 of the ulcer deaths, and it's rarely in the first indication of an ulcer. And obstruction from edema or scarring, which occurs in about 2% of patients, more often due to pyloric channel ulcers and due to duodenal ulcers. And this one causes that incapacitated, crampy abdominal pain. And very rarely the obstruction from edema or scarring will lead to total obstruction with intractable vomiting. That's very rare, but it does happen once in a little while. Now, that's a joke there. The font is so small that if I was in a classroom, I would ask, would this slide be seen in a real classroom to those sitting in the back row? And that's, those of you who have been taking classes with me before know how much of a cheapskate I am with slides and fonts and all that. Now let's go to the acute ulcers. Again, NSAIDs, stress ulcers, endogenous steroids, shock burns, massive trauma, intracranial trauma, intracranial surgery, sepsis, Cushing's ulcers. And remember, acute stress ulcers are highly related to an excess of endogenous or exogenous steroids. Not surprisingly, they are likened or compared to gastritis and oftenly misdiagnosed too. More than once, you will see a case, and it's not, trust me, it's not, it doesn't go down as medical malpractice. It's a very common that they might be confused with gastritis. And since it's part of a differential diagnosis, and depending on where you are in the circumstances, it's a relatively common mistake. To a point that most, I'd say most, courts throw away those kind of lawsuits involving misdiagnosis of acute gastritis with ulcers. The theory comes down to reasonableness. How reasonable a reasonable, prudent doctor, competent doctor might have led to believe, based on the symptoms, that the case was one of gastritis when in fact was acute ulcer. They get thrown out all the time. Those who settle, it's because, you know, they just want to get the case, water under the bridge, and move on. I deal a lot with this medical malpractice thing as a consultant. Acute ulcers, they're usually small, less than 1 centimeter, superficial or multiple, and this type of acute stress ulcer is often confused with ulceration from gastric intubation. But the difference is intubation ulcers are more linear. You see that linear, well-defined pattern that you say, wow, this looks almost like a perfect line that caused this ulcer. It was a perfect line because it was a tube, a man-made tube. That's why it looks so cool and so nice and so neat and less diffuse. And not unusual in autopsies, the stomachs that look like this one, and people whose death was preceded by extreme physiologic stress. In other words, the CFO, Chief Financial Officer, that was caught cooking the books for his corporation. Gastric dilatation, think about pyloric stenosis, peritonitis, caused by pyloric stenosis. Gastric juices, you should have between 1.5 to 2 liters is normal. 10 liters can be present in dilation. Acute rupture is associated with a high immediate mortality rate. Bezoars, pythobezoars, plant material, trichobezoars, hairballs, non-food material in psychiatric patients, pins.
The organizer has ended the session and